Thanks, John. If you just, under view, if you just go to full screen, it should show the full screen mode. Thank you. Good morning. My job is to talk a little bit about incorporating safety and quality into routine clinical care, and the topic of the session is safety and quality for beginners, so that's where I want to start. Now, I'm going to do something unusual and tell you how modest I am. Been in clinical intensivist for 30 years, worked for the department as a clinical advisor for 25 years, done research in safety and quality for 20 years, worked in the Victorian Intensive Care Data Review Committee as an advisor and analyser for 18 years. I've set up the Clinical Outcome Review Committee at a previous network and chaired it for the first 5 years. I've published about 20 articles on safety and quality topics, and 4 out of the 6 major in ICU ACHS indicators refer to stuff that I've published. So, what have I got to say about how to introduce safety and quality into the daily ward round? What can I tell you about bringing safety and quality to the bedside? What is my advice on trying to embed safety and quality into routine clinical care? Well, my first response is don't. Don't introduce safety and quality as your primary goal in clinical care. Now, before the organisers come in and throw me out for bringing me here to a safety and quality meeting to say don't focus on safety and quality, let me qualify what I mean. I'm suggesting that we shouldn't mix clinical care with safety and quality at the bedside, and we shouldn't try to focus on safety and quality because it's the wrong question to ask at the bedside. Now, if it's the wrong question for you to ask at the bedside, then there must be a right question. What is the right question? And already Monica and Michael have spoken about this right question, and that is the question, what is best for my patient? So if you focus at the bedside on the question, what is best for my patient, what I would suggest is that the automatic flow-on is that you will start to think about patient safety, quality of care, and start to think about how we can improve it, how we can do better. But what's wrong with focusing on safety and quality at the bedside? Well, what's wrong with it is that it's the wrong way round. It's the wrong focus. As I've already intimated, I'm suggesting that what we should be doing at the bedside is almost forgetting safety and quality and asking the question, what is best for my patient now? That will drive safety and quality. Whereas, if you think about it, the times that you've been asked to focus on and think about safety and quality at the bedside, it will often hinder clinical practice. Now, that seems bizarre, but I would suggest you think about it, and next time at the bedside and somebody comes and asks you to fill in a checklist or to collect some data for an audit program, just ask yourself, is this improving the quality of care that I'm giving to this patient right now? And could it be distracting me from doing what I should be doing? So I'm suggesting that the mindset ought to be what is best for patient care, not safety and quality. Safety and quality at the bedside is potentially a dangerous distraction and unnecessary burden, particularly on the nursing staff who are already working extremely hard. And it results in the unquality cycle. And you know, you've all seen this, I'm sure, where you get the amount of inspection increasing at the bedside and you're being watched more and more, and good workers become negative and jaded and they leave, and you get more meetings, you get blame and shame, and you get customer complaints because nobody's focusing on the patient, and in the end quality decreases. So what I'm suggesting is, if I can give you any bit of advice from my 30 years, at the bedside focus on what's best for patient care. Let me explain it. Safety and quality is a bit like falling in love. You all, I would presume, most of you, have fallen in love at least once in your lifetime. Remember what it was like. You were enchanted by a particular person. You were intrigued by them. You wanted to know more about them. You wanted to spend time with them. You wanted to do what was best for them. But the last thing you thought about was, I want to fall in love. What you were focusing on was the person. And in doing so, you found yourself in experiencing that feeling of love. Safety and quality is a bit like that. If you focus on what's best for the patient, what I'm suggesting is that safety and quality will flow on. So, what about engendering best practice for patients? Now, you all know of the quality cycle, which has already been shown to you, of the plan, act, review and improve. So how do we link safety and quality with clinical practice without mentioning those dreadful words at the bedside, or without labouring the bedside nurses, the bedside clinical staff, with having to fill in a whole lot of data sheets and checklists? Now, the first thing, and it's just like in life again, the first thing you do in any safety quality initiative is ask, what are we going to do? How are we going to do it? But by far the most important question to ask is, why on earth are we interested in safety and quality? And why on earth are we collecting this data? Why on earth are we analysing this data? Now, there are lots of good reasons why you would want to collect data about your patients, about your processes, and the type of care that you deliver and how you might improve it and whether you are improving. And here's a list of some of the legitimate reasons. So sometimes we need to collect audit data for statutory reasons. For example, in Victoria, we're required to benchmark our outcomes, and most of us use the ANZICS core data set, or for the adult patient database, or the ANZPIC paediatric database. Sometimes we need to collect data for research, and that requires us to collect audit and safety related data. Often our focus, fortunately, is quality of care, and we want to improve quality care, and you cannot improve quality of care if you don't know where your baseline is. So we need to set the baseline and then measure to see whether or not we've improved. A really important role in safety and quality is trying to affirm the staff who are doing all the hard work. So affirm and support and encourage particularly the nursing staff and the allied health staff at the bedside who are doing the hard work. Another important role of safety and quality is to reassure the community that a reasonable standard of care is being provided, reassure the healthcare managers and funders that their money is being spent wisely. But one caution I would bring up, and that is, beware the false religion of numerology. And what I mean by that is that when you go back to work, I want you to go to your performance boards up on the wall, if you have one, or your report, and have a look at each chart and ask the question, does this information tell me anything about the quality of care that we're delivering to our patients? I would suggest if you look at most of the ACH indicators, most of what's on your performance board, most of the clinical indicators that are published, they tell us very little about the actual true quality of care that we're delivering. There may be good reasons for collecting it, but beware that we should try and avoid collecting numbers just for the sake of collecting numbers. Think about your safety and quality department. How many people does it employ? What do they produce? A lot of the information, while it's useful and interesting, tells us very little about the real quality of care and patient safety. This comment is really for the managers, and I think it's really important for my next bit of advice that you choose your staff wisely. Why? Because if you choose the right staff, the right clinical staff at the bedside, safety and quality will be automatic. Whereas, if you just focus on safety and quality and you generate all the safety and quality initiatives that you like, you will never change if you've got the wrong staff at the bedside. And you all know that from real life. So it's very important that you make sure that you've got the right staff, and that within your unit you'll have some staff who are more interested in safety and quality than others, and they're the ones to encourage. And I observed only 3 weeks ago a junior nurse came to the nurse unit manager just off her own back and said, what can I do to help in terms of the audit processes going on in the unit? She volunteered because she wanted to. So if there are right staff, then there are obviously wrong staff. And what I would warn you is beware of the eternal optimist who wants to whitewash everything and make excuses that it's as good as it'll get and it'll never get any better. Beware, of course, of the pessimist. You all know the people who complain till the cows come home about all the problems. They can identify, they're very observant, they know exactly what the problems are, but they'll never give you solutions. Beware the selfish, ambitious egotist, particularly in medical circles, who just wants to climb the ladder and feather their own nest and is of no interest in the quality of care happening in the unit. And then beware of what I call the fiddler on the roof. Tradition, tradition, tradition. And things have always been this way and we can never change. So what do we measure? Well, there's a whole lot of things you can measure, and we try and classify clinical indicators and audits under these 5 categories. So we've got workload, which is basically about how much work you do, the case mix, the number of MET calls you go to, etc. Why is that helpful? It tells you nothing about the quality of care, but if you've got an extremely busy unit, it's going to affect care. If your workload goes up, it's going to affect quality of care. So you need to know something about your workload. Patient access is crucial, and I don't need to say anything more about this. Process of care audits is where most of the safety and audit work, quality work occurs. And whilst a lot of it's useful, just beware that you don't focus entirely on process of care and how often we do something. For example, what's the point of everybody washing their hands and having 100% compliance with hand hygiene if as soon as you go into bed you make the wrong diagnosis? What's the point of having a 0 CLABSI rate if you don't know how to interpret the central venous pressure or use a central line correctly? So whilst all of these things are useful, they unfortunately is where we tend to focus a lot of our efforts. But really, when you ask the question, very few of them tell us anything serious about the quality of care and patient safety. We need to know something about efficiency, and I'm happy to answer questions about that. And then we need to look at something to do with patient outcomes. PROMs, I view in terms of patient-related outcomes and patient-reported outcomes. Both of them are important. So once you've got that framework, pick 2 or 3 out of each of those categories and focus on them. You can't do everything. Focus on what you can do and do what you can within the resources that you've got. It may be that you pick 2 or 3 that you do every quarter or every month. You can't do everything, and then you rotate your audit cycle around so that every year you've got some idea on each of these categories. How do we measure? Well, it's really important to use simple data, not make it too complex, make it clinically relevant and reliable, and use existing data sources if you've got them. Most of us have. The amount of time and duration you spend in safety and quality will obviously hugely depend on your resources, so use your resources widely. Sometimes you're a big unit, you can actually put EFT towards it. Other times you're to say, well, I'm going to roster this shift towards audit and quality issues, but be careful not to mix it too much with the clinical care and cause an impairment of clinical care. The analysis of the data needs to be clinically and statistically robust and appropriate. Very important that on the review committees you have clinicians interpreting the data. And finally, the presentation needs to be nice and simple and unambiguous, so the message is clear to everyone, even to those who are not clinicians and those who are not statisticians, which is most of us. Finally, data is extremely powerful. And like James Bond's Walter PPK, the ammunition in it is extremely potent. But remember, data on its own is ambiguous. It doesn't know how to be used. It doesn't know whether it's being used for right or wrong. You must use the data carefully and prevent misinterpretation. So use your data wisely. My final comment practically is you need to engender trust. Trust within the unit and trust between the unit and your managers and the people that you report to. Sometimes, often, particularly when you're starting off in audit and quality, you need to gain that trust. So often you need to put in the work, show the data that supports the organisation and show that you can be trustworthy with the resources and the data. And I hope that's been of some help to you. And in summary, remember to focus on clinical care, not safety and quality. Remember to choose the right staff, know why you're doing it, select your audit processes carefully, don't try and do everything. Remember to collect the data as well and as reliably and accurately as you can. Protect it from misuse and misinterpretation, and earn the trustworthiness of those you report to, both above and below you. And that's my suggestions on how to introduce safety and quality into practical clinical care. Thank you.